and give and hand over to Leigh.
Thank you so much for this, Heini. I'm so excited to be here with you all to share a little bit about my work on measurement, and specifically how we can measure person-centered and rights-based outcomes in sexual and reproductive health. I'm really pleased to be here. So let me just dive right in. Just a brief outline of my talk today. I will start with just a little bit of background on coercion in family planning and some of the rationale for this project, before moving into a discussion of what I like to call the tacit ideology of measurement, which is something that I spend a lot of time thinking about. Then I'll move into a discussion of the contraceptive autonomy study, which is sort of the centerpiece of my research agenda, and I'll share some of my findings from that study, a little tiny bit of qual, violating the FemQuant ethos just a tad, to sort of give you a sense of how we're using the qual to inform the quant measures that we're developing. And then I want to spend a little bit of time talking about some of the lingering measurement challenges, some of the puzzles that we haven't quite solved yet, and then a few words about what I hope we can all take away from this. Okay, so let's get started with a little bit of context. And I like to start with the question, why should we care about global family planning measurement? And different people have different answers to why we should care about family planning. In the global discourse on family planning, there are like a myriad of different rationales that have been offered for why we should be promoting and expanding family planning services. Among these are a feminist rationale to promote contraception as a matter of rights and of bodily autonomy, an environmental rationale to protect biodiversity and alleviate climate change. There is an economic rationale to promote family planning as a way to increase economic growth and to reduce poverty, and a public health rationale to promote both maternal and child health. And I'm sure there are many more that we can all think of. And this is a screenshot from a family planning advocacy website that shows how several of these arguments are deployed at once. They call family planning, quote, the smartest investment we can make, capable of improving outcomes in everything from HIV/AIDS to education, to sanitation, to malaria, as well as bringing significant savings across sectors. And this is just one example of the ways that family planning is portrayed as a sort of panacea or a silver bullet for the multidimensional challenges of global poverty, unsafe living conditions, and ill health. And with so much upside and essentially no stated downside, the challenge in global family planning is framed as how we can maximize contraceptive uptake to its highest levels possible. But of course, we need to remember that despite all of these purported benefits, family planning has not always been an emancipatory endeavor for all people since its inception. Instead, family planning has been tied in with a wide range of efforts to control both fertility overall, as in the case with population control, but also to decide whose bodies are targeted for fertility reduction. In the United States in particular, the eugenics movement targeted the bodies of marginalized racial and ethnic groups, disabled people, people living in poverty, among others, for compulsory sterilization. This is a photo of civil rights activist Fannie Lou Hamer, who was a voting rights activist here in the US. But in addition to her work on voting rights, she also helped us get to know the term Mississippi appendectomy, which is a term that Black women in the US South used to describe their involuntary sterilization at the hands of white doctors. And this actually happened to Ms. Hamer herself. She was given a non-consented radical hysterectomy in 1961 when she was undergoing surgery for a small tumor. So the pioneering work of scholars like Dorothy Roberts, Loretta Ross, and many others have conceptualized the ways that intersecting identities of race, gender, and class have constructed poor Black women and other women of color as the targets of scientific racism and of reproductive coercion. Black feminist scholars and activists have elaborated the reproductive justice framework, which highlights the deficiency of existing white feminist paradigms to address these intersecting challenges and the challenges to reproductive well-being of Black women and other marginalized groups. And in particular, the RJ framework really focuses on the structural barriers to reproductive freedom and really notably expands the focus of reproductive rights beyond simply access to contraception and abortion, and defines reproductive rights as including the right to have a wanted child and to parent that child in safe and healthy communities. And I'm sure many of you already know about the reproductive justice framework, but what I really want to emphasize here is that while RJ has been increasingly influential in the domestic work here in the US and the work on reproductive health in the global north, the reproductive justice concept has not been nearly widely as applied by the global family planning community to programs in the global south. So let's turn our attention to the global south for a second. After the Second World War, NEO-MALTHUSIAN concerns about global overpopulation were really central to the birth of the international development sector. So USAID, the U.S. Agency for International Development, was founded in 1961. And in that very same year of its founding, the agency began funding family planning research as one of its very first activities. This is a screenshot from the USAID family planning website, and it shows how Presidents Kennedy, Johnson, and Nixon all motivated U.S. development assistance for family planning as a way to control overpopulation in poor countries. President Johnson in particular said that he would seek new ways to use our knowledge to help deal with the explosion in world population and the growing scarcity of world resources. And President Nixon called population growth one of the most serious challenges to human destiny. And given these really stark and even sort of like apocalyptic stakes, the legitimacy of coercion in the pursuit of fertility decline was frequently affirmed throughout this era. In 1979, the president of the Population Council published this paper advocating for what he called a stepladder approach to dealing with the so-called population problem, with Bernard Berelson and his colleague writing that there are undoubtedly cases of justified coercion, but he cautioned that overt violence or other potentially injurious coercion is not to be used before non-injurious coercion has been exhausted. So essentially, try to use the least violent means of coercion possible to still obtain the fertility decline that we really think is important. And so during this era, many countries in the global south adopted population policies that included economic penalties for high fertility, recruitment quotas for providers, and compulsory sterilization for women. Scholars such as Sonia Correa, Betsy Hartman, Gita Sen, and many others have described the ways that scientific racism, scientific misogyny, Western hegemony, these have all suffused the International Development Project from the beginning, and the particular ways that the gendered and racialized logics of global family planning programs target poor women of color living in poor countries for population control and fertility reduction. And so it's really important to note how feminists from around the world have organized to contest these types of reproductive violence that were being perpetrated on their bodies in the name of population control. Here you have a poster from our artist Rachel Romero. She created this image in 1977 to bring attention to the forced sterilizations that were going on at the time. And all of this really came to a head in 1994. That's the year that the UN organized its International Conference on Population and Development, ICPD, which took place in Cairo. And this conference really became this, like the well-known reckoning, where a substantial and well-organized feminist opposition confronted the population control movement and demanded an end to coercive family planning. And so to quote this article from The Lancet, the Cairo conference put the ideas of comprehensive sexual and reproductive health and rights, choice, women's empowerment, a life cycle approach, and gender equity at the center of the international agenda and signaled the end of the so-called population era. So there's sort of this conventional wisdom that the Cairo conference changed everything, and we have this thing that folks like to call the post-Cairo shift, in which the focus on population control and demographic targets is supposed to be replaced by a more holistic focus on reproductive health, gender equity, and rights. But it's my contention that this shift has been much more successful rhetorically than it has been substantively, and that the orientation towards fertility reduction still remains very much intact in global family planning programs today. And I can show you just a few examples of state-sanctioned coercion in the years since the Cairo conference from all over the world. There have been efforts to control fertility overall, like the one-child policy in China that was in effect until 2016. or these sterilization camps in India, which also operated through 2016. There have been efforts focusing on ethnic minorities, like in Peru, where indigenous women were targeted under the Fujimori government until the year 2000. There have been efforts targeting the bodies of folks with disabilities or living with chronic diseases. This example from Namibia looks at women living with HIV who were targeted in 2012. There have been cases where women of color, Black women, women of African descent are targeted, like this case from Israel from 2013. Instances where trans folks are targeted, like this example from Europe, and I believe France in particular in 2017. Instances where poor people are targeted, like this example from Australia from 2014. And instances where incarcerated people are targeted, like this example from here in the US from 2017. And so here you have examples of contemporary contraceptive coercion from every inhabited continent in the world, targeting just about every kind of marginalized group you can think of across axes of race, ethnicity, gender, disability, class, geography, and more. Right, so like I don't have any news stories of contraceptive coercion on Antarctica, but I bet if we get a couple more people living on Antarctica, we'll soon have news stories coming from there too. It's just like everywhere there are people, we're seeing examples of this types of reproductive coercion. But I think it's important to note that these sort of headline-making cases of rights abuses are a really far cry from how most mainstream family planning programs operate day to day. It's important to note that most mainstream family planning programs have denounced these types of overtly coercive practices. And family planning community really takes a lot of care actually to affirm the importance of voluntarism in all these programs. So it would be, I think, easy and indeed tempting to dismiss all of these cases that I just showed you as outliers, perhaps the result of a few rogue providers or some out-of-touch bureaucrats or some folks who don't get it, but not as indicative of sort of the heart of the family planning community. But I want to push back on that a little bit here today and argue that I think that same population control mentality actually does very much manifest throughout mainstream family planning and throughout the scholarly work on family planning in particular, but of course in ways that are much more subtle, that aren't sort of advocating for overt coercion. So here, for example, we have an example from some prominent demographers in the Bulletin of the World Health Organization. The paper is entitled Family Planning in Sub-Saharan Africa, Progress or Stagnation. And the authors write that the paper comes from a, quote, concern that uncontrolled population growth will hinder the attainment of development and health goals in Africa. And that the paper comes from, quote, the assumption that fertility will decline only if the population at large adopts effective methods of modern contraception. And these types of claims are incredibly common throughout the public health and demography literatures around global family planning. So this ideological orientation towards slowing population growth through increasing contraceptive uptake, it has really important implications for how scholars approach the study of family planning. And so that makes me want to talk to you next about what I'm calling the tacit ideology of our family planning measurements. And I know I don't need to convince this group of feminist quantitative scholars that measurement matters in all kinds of important ways. But it's still, I think, important to turn to some of our anthropological colleagues, our ethnographic colleagues, who have been pioneering the sort of social science interrogation of quantification. And I love this quote from anthropologist Sally Engel Mary in particular from her book, The Seductions of Quantification. Mary writes that statistical knowledge is often viewed as non-political by its creators and users. It flies under the radar of social and political analysis as a form of power. Yet how such numerical assessments are created, produced, cast into the world, and used has significant implications for the way the world is understood and governed. So what Mary is arguing is that although indicators seem like objective counts of a given phenomenon, specifically what we choose to count and how we choose to count that thing, these are actually very political decisions that reflect the political worldviews of the people who are making them. And so I spend, I would say, the bulk of my time in my work thinking through what are the tacit ideologies of our global family planning measures, What types of power are these measures wielding? Whose worldview do these indicators help us see? And really importantly, whose worldview do our current indicators currently obscure? And so here's a list of some of our really common population-based indicators that we use in global family planning today. If we look at what's actually being measured here, we can see measures of contraceptive use, for example, in CPR, contraceptive prevalence, measures of fertility desires, for example, unmet need incorporates pregnancy intentions. We can see age-specific fertility outcomes in the total fertility rate or the adolescent fertility rate. So we're measuring fertility, we're measuring contraceptive use, but it almost sort of took my breath away when I first realized that actually none of these measures, none of the things that we measure is measuring a health outcome. None of these is a health outcome. None of these is measuring anything to do with rights. None of them is measuring access. None of them is measuring equity. Really conspicuously absent from this list is anything to do with that post-Cairo agenda that we're supposedly promoting now in our programs. So what I argue is that while our motivations, our rhetoric for family planning has been really radically transformed in the years since Cairo, our measurements have not followed suit. And that's resulted in this really fundamental misalignment between what we say we're doing and our stated goals that motivate our programs and our current measures. And what we measure and how, of course, is not just a question of academic interest, but it has really important implications for how programs get funded, how they get designed, how they get implemented, how they get evaluated. And this is particularly true in the global health world, where a discrete set of quantitative indicators is tremendously important for things like, say, the Millennium Development Goals or the Sustainable Development Goals. We use these quantitative measures to really to set the agenda for global health. And global family planning in particular has seen an increased reliance on quantitative target setting in the past decade. I'm sure many of you are familiar with this initiative called Family Planning 2020, FP 2020, which began in 2012 and was led and funded in large part by the Bill and Melinda Gates Foundation, along with several other funders. And FP 2020's main objective was to reach a quantitative target to add 120 million additional users of modern contraceptive methods by 2020 in the world's poorest countries. And in the words of the program's architects, the success of FP 2020 will first be evaluated on the basis of quantitative verification to determine that the 120 by 20 goal was reached. And then this overarching global target in turn spawned a range of regional and national targets that were pursued and measured in much the same way. So the way it worked was countries would make formal commitments to the FP20 initiative. Here's just a few examples. You can see the Ouagadougou Partnership, which was a partnership of 9 countries in Francophone West Africa. They pledged to add 2.2 million additional users of contraception in their countries. You can see Haiti pledged to increase modern contraceptive prevalence there by 10%. And really interestingly, Ghana's goal didn't just include a contraceptive uptake target, but Ghana also pledged to reduce their total fertility from 5.5 to 3 children per woman. So a 2.5% reduction in children per woman as part of their commitment to this initiative. So it's really this global context that led to the 2 overarching research questions that guide my contraceptive autonomy study. The first is, what happens to people's experiences if and when fertility goals are what drives family planning programs? And the second question is, given the importance of quantitative measures, how can we design population-based family planning indicators that measure and promote this post-Cairo agenda of reproductive health and autonomy, as opposed to the pre-Cairo agenda of population control? We have this big study that I want to spend the rest of our time together today talking about. And I just want to give you sort of a brief overview of the study as a whole before I dive into the details. It's an exploratory sequential mixed method study that I designed that uses a formative qualitative research phase to then inform the development and implementation of a large-scale quantitative survey. And for our purposes today, I'll be anonymizing the country setting where this where this study took place, but to suffice it to say that it's a country in sub-Saharan Africa that has won international acclaim for its family planning program in recent years. And so the idea is that if coercion is found in this highly visible and award-winning program, it might be reasonable to hypothesize that similar types of coercion may be a problem throughout similarly conceived family planning programs in the global South. In terms of our mixed methods, our qualitative phase consisted of in-depth interviews with women of reproductive age, focus group discussions, and key informant interviews with health administrators. And these this qualitative portion really helped us understand what kind of experiences people were having, what types of languages they were using to talk about those experiences, and what kind of survey questions might then make sense given those experiences. And then we used the data from that phase to develop a novel questionnaire with many novel survey items and implement this large population-based survey at 2 research sites among over 3,900 women of reproductive age. And as I mentioned, I'm going to give you just a teeny tiny taste of our qualitative findings so you can sort of see what we use to then inform our item development. So our qualitative findings led me to develop what I call my comprehensive theory of coercion, which includes sort of the 3 tenets that 1, coercion sits on a spectrum, 2, coercion is structural, and 3, coercion is bidirectional. And I'll explain what I mean by each of these. So first, coercion sits on a spectrum. This is, I think, one of the most important findings of this work. And it's really that rather thinking of coercion as a binary outcome, I think it's actually much more helpful to conceptualize coercion as an array of practices that limit contraceptive decision-making. And this array of practices can include things that are very, very subtle, as well as things that are very, very overt. So things like biased counseling, limited method mix, and the provision of false medical information. We map these as subtle coercion, threats to deny future care, scare tactics, insisting until a person accepts. We map these as moderate coercion, and then inserting methods without consent and refusing to remove a LARC method. We map those as overt coercion. And so this, I think, really helps us understand things like a limited method mix, which perhaps before we wouldn't consider to be a form of coercion. It helps us to understand the way that it's still part of an array of structural forces that limit contraceptive autonomy. So here's an example of what I mean when I talk about structural coercion. This is Maria's story. We asked Maria to tell us about her contraceptive counseling, and Maria replies, well, the health workers normally counsel you that if you want to choose, you have to choose the 5 years, by which she means the implant. Now, if that method isn't suitable for you, you can take it out and get the 3 months, the injectable. But if you don't like that, you can't take it out. You have to wait for the 3 months to be over. Otherwise, you can't remove it. So it's the providers who told you. It's true that there's counseling and they tell you to choose what you like, but what they think is best, it's only the 5 years. So again, this might be the kind of interaction that previously might not be considered coercive. We might talk about this as a form of provider bias or low quality of care, but perhaps not coercion. There's no use of threats. There's no use of violence. But I think it's clear from this excerpt that Maria is describing a situation in which her contraceptive autonomy is severely constrained by the family planning program. I know here's an example of what our in-depth interviews told us about overt coercion. This is Jessica's story. Jessica tells us, when I got pregnant with my 10th, the midwife told me that I have a lot of children and that I would have a difficult delivery. The health workers in a nearby town said that I needed to get the implant by force. I was obligated to accept, and they gave me the implant. The nurse told me that it would be 5 years, and even before the date of the 5th year, I started to feel illnesses due to the implant. I went to tell the hospital that I got headaches from the implant, and it's there that the health worker told me that the date to remove it hasn't yet arrived, so he can't remove it. He refused. He said it hasn't yet been 5 years, and there are 2 months that still remain. So there's a lot going on here with Jessica's story, but I just want to focus in on a few key things. One, Jessica was forced to get an implant due to the provider's perception of high parity. It does not seem that she was given any choice about whether to use a method at all or what method she would be provided. And then instead of viewing the 5-year duration of the implant as the maximum period of efficacy, as intended, many women told us stories about providers treating that 5-year duration as the minimum duration of use and refusing to take LARCs out before that total label duration of use had elapsed. And so in this case, we can see that a provider is, I think, very clearly forcing Jessica to keep a method that she wants to discontinue. So that's our spectrum of coercion. Now here's an example of what I'm calling structural coercion. We spoke to a health administrator who supervises family planning clinics, and he explains to us that at the district level, we also give goals to each health center so they can attain the targets, those that are concerned with all of the methods mixed together, but above all, the long-acting methods that we're really emphasizing. So this quote from the administrator now sort of helps us put into perspective why Maria's provider was so insistent on the implant and why Jessica's provider was so insistent on the implant. These are not, I don't necessarily think, cases of provider bias or individual malice, but really people operating under structural conditions that are incentivizing certain outcomes and disincentivizing certain others. Right, so if we understand contraceptive coercion as something structural, something that stems from policies and programs, rather than something that's the result of a few bad apples, we can, I think, get a much better understanding of how to address coercion. If instead of focusing on the intent to coerce by individual providers, we focus on policies and programs, then we can have a much easier time of devising solutions. And so I think this is important for a number of reasons, but one of them is that instead of blaming individual providers, understanding coercion as structural can help us reframe the situation and place the critique back onto the donors and the program designers in the global north who really created these incentives, as opposed to sort of blaming and scapegoating the individual providers who were really just doing what the program was designed to do. See, sorry about that. And then finally, I'm not going to spend too much time here, but I did want to also explain what I mean when I say coercion is bidirectional. Traditionally, coercion has been conceived of as when someone is forced to use a method that they don't want. So those examples from Maria and Jessica that we just saw are sort of classic examples of what I'm calling upward coercion. And this is indeed a very troubling form of coercion, but it's not the only form. What about when people are deprived of a method that they want? Here, I call that inability to use a wanted method, I call that downward coercion. Again, this is something that we've described before a lot in the literature as sort of a lack of access, barriers to care, but we haven't traditionally considered that a type of coercion. And I argue that considering this a type of coercion is really important to sort of help us conceptualize globally the way that women and other folks are not able to exercise the contraceptive practices that they want and are kept from manifesting their reproductive desires. So again, this is sort of what we're calling the novel theory of coercion. But how do we design survey questions and develop a new quantitative indicator to measure this new understanding of coercion? So here we go. This is sort of what we were thinking of. We know we have to do something pretty different than what the status quo is doing. For most of recent history, the outcome of interest to the family planning community has been contraceptive use. And we've been defining and measuring that in a really straightforward way, in which a person using a method is considered a good outcome. And when a person is not using a method, that's considered a bad outcome. And this sort of very simple dichotomous understanding of family planning success is at the core of just about every population-based family planning indicator that we have, ranging from contraceptive prevalence to unmet need. This is sort of what's at the core of all of our indicators. But if we add on just one additional criterion to what we measure, and we also start to examine the extent to which a person wants a family planning method, we can begin to create a much more person-centered understanding of what's going on. So I ask that if we add the second criterion, is the column to the right still always good? And is the column to the left still always bad? I suggest a new definition of success for family planning that's not dependent on a person's status as a contraceptive user or non-user, but rather is based on a concordance between what a person wants and what they have. And so it's based on this concordance that I propose a new measure of contraceptive autonomy. And this is the easy part. Like this sort of simple conceptualization is the easy part. But now comes the hard part, which is, what does it mean to want family planning? How can we create a measurement around this when, of course, we know that a lot more goes into autonomous decision-making than just a person's feelings, right? So we defined contraceptive autonomy as the factors that are necessary for a person to decide for themselves what they want in regards to contraception, and then to realize that decision. And then using that definition of contraceptive autonomy, I identified these 3 subdomains, inspired in large part by the work of Karen Newman and Charlotte Feldman Jacobs. So we have this operational definition of informed choice, in which a person needs to have sufficient unbiased information about a range of family planning options, including benefits and risks of both use and non-use. For full choice, a person needs to have access to a sufficiently wide range of methods from which to choose. And for free choice, a person needs to make a decision about whether or not to use contraception and what method to use voluntarily without barriers or coercion. So I'm hoping you can start seeing a connection between some of the examples I gave you of coercion from our qualitative piece in how we are understanding contraceptive autonomy here. So then we set about to develop new survey items and sort of a measurement algorithm that seeks to quantify each of these 3 subdomains. And I'm going to show you that algorithm in just a second. But before I go on to the algorithm, I want to explain to you what I mean when I say contraceptive attribute groups. So it's unreasonable to expect any health system, no matter how good, to be able to make every contraceptive method available to every single person at all times. So in the absence of perfect access to every single method, I've tried to enumerate the basic qualities and attributes that I think a well-rounded contraceptive method mix might have that would provide folks with access to a sufficiently wide selection, even in the absence of some methods. So the idea here is that a broad contraceptive method mix should include both a long-acting and a short-acting method, a hormonal method and a non-hormonal method, a coitally dependent method and a coitally independent method, etc. So keep these contraceptive attribute groups in mind now as I move on to the algorithm. So this is how we're proposing to measure each of the 3 subdomains of contraceptive autonomy. We propose that we measure informed choice as when someone knows how to use a method from each of those contraceptive attribute groups that I just mentioned. Someone who knows a benefit of non-use, as well as a risk of contraceptive non-use. If the person is a current user of family planning, I add that they should know both a benefit and a risk of their current method, and that they should know what to do in case of side effects. If they're a user of a LARC method or a permanent method, I also add that they should have been told either about method removal or permanence at the time of method provision. We say that a person has full choice if a method from each of those attribute groups is both available and affordable to them. This is like self-reported availability and affordability. And for LARC users, we further specify that removal services too should be both available and affordable. And for free choice, we say that people should have made the choice to use or not use family planning voluntarily. They should not have been offered incentives to either use or not use a method. And for current users, we add that they should have felt that they were able to refuse their method and that they're not using their method against their will. And then of course, for LARC users, we add that they should not have met provider resistance to method removal. So again, I'm hoping you can see some of the lessons that we learned from the qualitative portion show up in how we're trying to operationalize these concepts. So now if we go back to our contingency table, we can conceptualize who's falling into each of these cells. In box A, we have people who made a free, full, and informed decision not to use family planning, autonomous non-users. In box B, we have people who are using a family planning method, but did not have full information, access, or freedom in that choice. That also corresponds to our notion of upward coercion. In box C, we have people who do not have a family planning method, but did not have full information, access, or freedom in that choice. This is corresponding to downward coercion. And in box D, we have autonomous users, people who had full, free, and informed choice in their decision to use a family planning method. And now based on this schematic, we can start thinking about new measurements. And the first measurement that I propose based on the schematic is the simplest one, and I think perhaps the most important one. It's the contraceptive autonomy score, and it's the simple proportion of autonomous users over the population as a whole, which would be A plus D over A plus B plus C plus D in the schematic. And this might not seem like that big of a deal to folks, but to my knowledge, this is the first population-based family planning indicator that acknowledges that autonomous non-use of contraception is a perfectly good outcome. And if you think about it, if we pursued contraceptive autonomy targets instead of contraceptive uptake targets, we could eliminate some of those structural incentives for coercion that we saw in the qualitative piece. I'm also proposing an application of the autonomy score to contraceptive prevalence calculations. So the standard CPR calculation is just a simple measure of contraceptive users divided by the total population of reproductive aged women. So standard CPR in the schematic is B plus D over A plus B plus C plus D. I'm sorry, the coloring is wrong on this slide. It should be B and D highlighted. So anyone who's using a contraceptive method. But oops, I'm sorry, it's highlighted wrong here. This should just be D. In our new definition of success, I posit that folks in cell B, those who are using a method but lacked autonomy when getting their method, these are actually failure stories, not success stories. So I propose an autonomy adjustment to the CPR in which women who are using a method non-autonomously are removed from the numerator. And this leaves us only with autonomous users, women in cell D, in our numerator. Those are the only people who count towards contraceptive prevalence. And again, what would be helpful about this indicator is that it would remove any incentive for providers or programs to use coercion to meet their contraceptive uptake targets. So using the standard CPR, for example, if a woman is coerced into using an IUD, that looks good on paper because the IUD is recorded and the coercion isn't. But using the autonomy adjusted CPR, if she were coerced into using the IUD, that would no longer count towards the CPR, thus removing some of those structural coercion incentives. And then finally, we have a new conception of unmet need that I am thinking through based on cell C, this concept of downward coercion. These are people who are not using a method, but they lacked informed choice, full choice, or free choice in their decision not to use a method. And of course, this is a pretty radical departure from our current measurement approach to unmet need, which is based much more on pregnancy intentions than it is on contraceptive choice. And then just to give you all a really simplified understanding about how we bring all of these different items together into a single contraceptive autonomy score, I'm showing you here two of the different possible approaches that we're considering. The first approach is what we're calling the all or nothing approach, and it's based on the idea that the components of autonomy are mutually constitutive, and you can't have any autonomy if you don't have all autonomy. So if one of these things is missing, you don't have autonomy. So that's what we're calling our all or nothing approach. And the second variation of this calculation is based on the idea that actually, just because you're missing one or two things or three or four things doesn't mean you don't have any autonomy at all, and that a sort of partial credit should be possible. So in this case, rather than a person getting a 1 or a 0 for contraceptive autonomy, we're basically coming up with the average proportion of each of those 16 algorithm items that each person has in a given population. And both conceptually and methodologically, these are really divergent approaches to the measurement of contraceptive autonomy. And I'd love to talk through with all of you what you see some of the advantages and disadvantages to both of these approaches. And just a really preliminary look at some of our results here. This is the all or nothing approach disaggregated by contraceptive status. So the pink bar all the way on the left, that represents the contraceptive autonomy score of non-users. Green is all contraceptive users. Yellow is non-LARC users. Blue is LARC users, and gray is all of the women in the sample. And what you can see here, I think, is a little bit of variation across these groups, but really the results are pretty consistent across the board by contraceptive use status. So informed choice is really low in this sample, ranging from 6% to 15% of respondents by contraceptive use status. Levels of full choice were higher, but still not high, hovering at about half the sample. And then levels of free choice are much higher, about 95% of respondents across all contraceptive use statuses. And when we bring these together using this all or nothing approach, we see very low levels of contraceptive autonomy, from about 4% to 8% of folks depending on their contraceptive use status. And these incredibly low numbers are driven primarily by low levels of informed choice. If we look at the shades of gray approach, we can see much higher numbers here, which of course makes sense given the different methodological underpinnings. Here we're seeing levels of informed choice closer to 50, 60, 70%, depending on contraceptive use status. Full choice is between 60 and 80%, and free choice here is up above 97% for all groups. And so overall contraceptive autonomy is also much higher too. Again, this is an average number as opposed to sort of an all or nothing. So overall contraceptive autonomy ranges between 71% and 86% of all of our respondents. And I guess we want to take a second here to caution against the direct comparison of these two approaches, given how different the interpretation is of the all or nothing score versus the shades of gray score. They really are measuring quite different things. The all or nothing approach is much stricter in its adherence to the conceptual underpinnings of the indicator and is perhaps like a truer measurement of the construct of contraceptive autonomy. You can say in the all or nothing approach, this is how many women had contraceptive autonomy. But of course, that clarity comes at the cost of sensitivity to change. And the all or nothing approach might really fail to reflect important but incomplete improvements in contraceptive autonomy. This shades of gray approach will be much more sensitive to small changes over time, but that sensitivity really comes at the cost of a sort of conceptual haziness and a much less interpretable result. And if we choose to go ahead with this shades of gray approach, we might even want to consider a weighting scheme for the final survey items, depending on their relative severity. So things that we consider to be more severe threats to contraceptive autonomy might be weighted more strongly than things that we consider to be less severe threats. And I don't want to spend too much time here, but I do want to just mention before I close some of the lingering measurement challenges that we're dealing with here. I certainly do not think that we have a perfect final measure here, but rather we've taken a few steps on a long road to figuring out how to best measure the construct of autonomy. And I'm not going to talk about all of the things that we're still unsure about, although that list is very long. Let me highlight one thing, which is how do we measure free choice? Long story short is that I think this is really hard and I don't think we have it quite right yet. The qualitative data that I briefly discussed with you earlier really seemed to suggest that pressure to use methods and provider to remove LARC methods was pretty commonplace among our communities. We saw this come up again and again in our focus groups, in our in-depth interviews. Of course, those methods can't be used to measure prevalence, but we really got a sense in our qualitative results that these were pretty commonplace phenomena. And then when we asked in our quantitative survey, even though we had done all of this testing and item development and cognitive interviews, we still saw that very few people answered yes to feelings of pressure or non-voluntarism in their family planning decision-making. Of course, one explanation could be that truly not that many people are experiencing non-voluntarism and that our questions are revealing an accurate estimate of the true population levels of contraceptive coercion. This is, of course, one very plausible explanation for the results. But again, based on our qualitative findings, I think I'm much more inclined to believe that contraceptive coercion is indeed an important factor in these communities, but we haven't found the right way to measure it yet. There's a ton at play here, including, for example, women not wanting to admit even to themselves that they have been coerced, or doing some post hoc cognitive work to reconcile the cognitive dissonance that they feel about wanting to believe that their providers have their best interests at heart and not wanting to believe that they were coerced. And of course, there might be a strong social desirability bias at play here, with people not wanting to admit to an interviewer what's going on, especially if they think that that interview might in some way be connected to the health system. And so there are a lot of different things that we can think of that might be affecting our ability to accurately measure free choice through survey questions. Some of these might be addressable through development of better survey questions and better cognitive testing of item wording, but we might also be facing a sort of fundamental issue here of survey measurability, much the way we do with abortion questions, where like maybe we'll just never be able to measure this accurately through self-reports. So we still have a lot of work here to do to untangle things. We're also thinking through some issues around the eventual psychometric validation of this measure. We're working on a sort of alternate approach to indicator development that relies on psychometric methods to sort of pull out the best algorithm items as opposed to sort of us deciding how we think the algorithm should be defined. So we tested actually over 80 novel survey questions in our survey, and these are just a few examples of some of the other ways that we're thinking we might be able to measure informed choice, full choice, and free choice. And we're planning to use some of these latent variable modeling approaches to see actually which of these questions are sort of doing the best job at measuring the latent constructs. And we have some, I think, exciting things planned with some advanced psychometric methods, including multidimensional item response theory, multiple indicator, multiple cause models, and this issue of identifying the construct of autonomy as a formative indicator rather than a reflective indicator. And that's something that we can talk about a little bit more in the Q&A if folks are interested in that. The long-term version for this project is to have this indicator be measured around the world. Wherever there's a family planning program, I'd like to be measuring autonomy. And since routine measurement is key, the ultimate goal is to develop a module that is concise enough and important enough to be added onto pre-existing population-based surveys like the DHS in the Global South or the NSFG here in the US. And this institutionalization would allow for widespread calculation and comparison across both time and place. And so now just to sum up a bit what I hope we can take away from all of this. This study adds to our body of knowledge about family planning by conceptualizing contraceptive coercion and autonomy, and situates these phenomena as part of a racialized, gendered, and politically contested development initiative. Our study finds that a range of coercive practices from the subtle to the overt can be found even in a model family planning program, as long as that family planning program is motivated by contraceptive uptake targets. And we argue that new modes of measurement can help show the ways that programs are providing or failing to provide person-centered care. These results argue for a decolonial approach and a reproductive justice-based approach to global family planning that strips the power from donors and governments in the global north, and instead resituates the locus of power and decision-making within the communities that are affected by these policies. And then finally, we need to develop a range of quantitative measures that center women's voices and the voices of contraceptive users and their own desires for their bodies and for their lives. And again, I'll emphasize that this study is a first step on that path, but we have a really, really, really long way to go. So with that, I'd like to acknowledge the funders of this project, without whom it wouldn't have been possible. And thank you all very much for listening.
Thank you so much. I'm just going to start